I'm going to talk on the management strategy for thin endometrium in ART. Whenever there is an IUI or IVF cycle failure, a lot of questions are raised, and I say that no clear answer finally comes out. We know the known facts are, just now Dr. Sharma has said that, that monthly fecundity rate is in a normal couple is around 20 to 25% per cycle. But it is 60% of the IVF cycles do not end in pregnancy. That's a fact. We've been trying very hard to make the results to improve, but the results have hardly improved over a period of time, maybe making a difference of 10 to 15%. Now, patients need to have a realistic expectation of success. That's very, very important. What went wrong with me, with my cycle, with my protocols, or at the lab level? As Dr. Sharma just now mentioned, it is the egg, the quality of the beej hai aapka, that is very important for the success. But at the same time, egg quality is very much important, and so is the sperm quality. But the uterus also contributes to 10% as far as success of IVF is concerned. The hard facts are that healthy seeds just is not enough to get a healthy plant unless it is grown on a fertile soil. So that remains a fact. Similarly, healthy embryo needs receptive endometrium for successful implantation. Sir just now mentioned about the pregnancy happening in liver and things like that, but that is only just a drop in the ocean of that kind of things. Majority of the pregnancy take place in the uterus, and lining of the uterus becomes very, very important. It is a fact that we know much less on this particular aspect. Does not mean that we can ignore the endometrium anymore. Now, as for the USP of the endometrium is concerned, human endometrium is highly regenerative tissue. It is regenerative potential is compared to the bone marrow, epidermis, and the intestinal lining. Then why fertility and implantation in human beings is naturally low if endometrial thickness is less than 7 millimeter? Endometrium function and endometrial receptivity is a major limiting factor, and I will try to answer a few of things. Today we have improved all aspects of IVF, but still the average pregnancy rate is around 40 to 50%. It cannot be further increased. The bottleneck is the process of implantation. This is the bottleneck. Implantation is the most vital part of reproduction. Unfortunately, is the least understood part. In fact, it can be regarded as a rate limiting factor in reproduction. What we all know that the ET should be less than 16 millimeter and more than 7 millimeter or more. Not that it does not happen in less than 7 millimeter, but the chances are very low. Now, what should we do in such cases? It's very important that we must exclude tuberculous endometritis. This country is the land of tuberculosis, and it is an USP. Routine screening for genital tuberculosis with endometrial TB PCR and or histopathologically we can do it, but the yield by the histopathology alone is very low. India is, as you all know, is a high on a TB burden, even without symptoms. Patient may not have any symptom at all, and still you can find the tuberculosis is found, genital tuberculosis is found. Another thing I would like to have a comment by Brig Sharma and other experts who are here. We find that at times, there is a negative MON2 and interferon gamma release assay, which is supposed to be very, very sensitive. If they are negative, it does not rule out local tuberculosis in the genital tract. We find that 10% of our cases where we find that this IGRA test is negative, and still we find genital cox is found on the TB PCR. Now, saline infusion sonography, which we call SIS, or hysteroscopy in thin endometrium, This particular test is very dear to me, and I think, it is mandatory to rule out intrauterine adhesions. From patient may deny any history of a past DNC, and this can often be the case. But SIS is a good first-line, cost-effective screening, and I think each and everybody who is an ART expert should know this particular basic investigation. Another thing which is very important is thorough cycle monitoring. Document endometrial thickness pattern, triple line appearance is crucial. And also, if you are trained to do Dopplers, you should do a Doppler blood flow, uterine artery, PI and RI, or subendometrial flow also, in case if you can do it across multiple cycles since the time patient registers to you. It is not just in one failed cycle that you should be monitoring, but you should be monitoring otherwise. In fact, it is a practice with us is that we make a table that any time when a patient has come, we write down day of the cycle when she had come, and we document endometrial thickness. Another thing which I wish to share with each one of you is our ruling out chronic endometritis. Now, this particular test is available in good labs. We send it to a pathology lab, Lars lab, and this test is done. Where we perform endometrial biopsy, send it for CD138. It is an immunohistochemistry test. And specific PCR panels for common pathogens can be done. But this particular test where we do it by immunohistochemistry, CD138, we have started doing it. Chronic endometritis is a common problem and it is a treatable cause. As for the hormonal profile is concerned, again, we need to check mid-luteal progesterone to rule out luteal phase defect. And at the same time, we must assess the FSH, AMH, and the thyroid function as well, that is TSH. Evaluate estrogen response. I think whenever a patient is referred to us with a thin endometrium, I believe that before we take her up for IVF cycle, trial of a high-dose estrogen in a non-treatment cycle to see if the lining responds. Distinguishing it from a true refractory cases from a protocol issues. So I think, this trial of 1 or 2 cycles must be done, and if you find there's a satisfactory response, then only we should ask to start her on IVF cycle. Now coming to the medical management. These are the investigative part I highlighted, but coming to the medical management, which are evidence-based and workable. I will say optimize estrogen support, increase or individualize estrogen supplementation. Sir just now talked about estrogen valerate, that it may not be effective, then you can try estrogen hemihydrate and transdermal patches, which are not available, but the gel is available. And sometimes you use the same tablets vaginally also to enhance endometrial proliferation when endometrial thickness is earlier found to be less than 7 millimeter. Now, another policy is to use it extended modified estrogen protocols. Again, there may be problem of estrogen receptors. In this lower dose of estrogen, 4 to 6 milligram oral estradiol, valerate or hemihydrate is started early on the day 1 of the previous cycle, or it can be little luteal phase and continued for 14 days before progesterone. So it is, instead of normal 15 days, you extend it for almost 30 days, the proliferative phase, before you add on to progesterone. It mimics natural prolonged estrogen exposure. Transdermal, transvaginal estrogen, I again say consider gel or for potentially higher local tissue concentration and avoidance. These definitely avoid the first-class metabolism through the liver in such cases. Now coming to the aspirin, low dose. 75 to 100 milligrams, 75 milligram, we normally use it. We start from the cycle start. It improves the microcirculation. It has a weak evidence, but it is effective definitely in cases of thin endometrium. Now, to enhance endometrial perfusion, Vaginal sildenafil, there's a strong evidence that 25 milligram of suppository 3 to 4 times daily, starting from day 1 of estrogen until the trigger or the progesterone are added. It is well tolerated. Significant improvement in endometrial thickness is seen, and the pregnancy rate in RCTs are documented with the strong evidence. As far as vitamin E and pentoxifylline combination is concerned, it improves blood flow and potentially reduces fibrosis. Requires 2 to 3 months of a pre-treatment with such treatment. I have no personal experience of mine with this particular thing, but one of my colleague, Dr. Abhishek, used to use this particular molecule. Please mute yourself, please. Now, address chronic endometritis. Treat chronic endometritis once diagnosed aggressively. Based on the sensitivity, you give doxycycline plus a metronidazole combination, or you can use a ciproflox plus metronidazole combination for 14 days. Confirm cure with repeat biopsy before you proceed onto the treatment. Chronic endometritis, we find that in a regenerative approach, like using your stem cells in such patients, which we call a peripheral mononuclear cells, which are autologous. Patients' own cells are used, and for intrauterine irrigation, these are immune cells and create an immunogenic response. In the similar way, we find that in such cases, GCSF therapy also works very well. Dramatically, I will talk in another slide about the use of GCSF. It dramatically improves the clinical pregnancy rate from 40% to almost 75%. Stem cell treatment showed a promise as well. Now, as far as the treatment of genital cox is concerned, full antitubercular course should be given of 6 months, and you need to reevaluate after confirming the cure. Only you start the ART cycle. Now, as far as L-arginine supplementation is concerned, this is a practice that each and every ART person expert is using it. 6 gram is the dose of a daily dose orally. It's in the form of the liquid. You have to make a liquid preparation, and the sachet comes of 3 grams. 6 grams per day, and this acts as a vasodilator. It's a precursor for nitric oxide, and it's a good evidence for improved in endometrial thickness is seen in such patients. Now, coming to the granulocyte colony stimulating factor, recombinant preparations are available. It is off-label use, but increasingly being used. Subcutaneously, 300 microgram. We use it in such patients on the 7th and the 8th day, and then use intrauterine infusion around the time of ovulation to see that the endometrial thickness is increased. Promising RCT data showing significant improvement in endometrial thickness and pregnancy rate in refractory cases. This is one of the very favorite modality as far as thin endometrium is concerned. Vitamin E supplementation in the dose of 800 to 1000 international unit. It is definitely an antioxidant and may improve the endometrial receptivity as well. Coming to the platelet-rich plasma, PRP. Intrauterine infusion, again, we believe that many people say that only 0.5 ml should be used in the treatment cycle. But otherwise, once you're trying, before you have taken this patient for IVF cycle, you're trying it out. In such cases, we make a PRP, and we use almost 3 ml timed around ovulation to increase the endometrial thickness. Autologous growth factors, rich PRP, promote proliferation and angiogenesis. Growing evidence supports efficacy in the refractory thin endometrium. And again, I repeat, this must be tried out at 1 or 2 cycles before the actual treatment starts. So you exactly know that you will be able to take care of this thin endometrium. Now, coming to the surgical and procedural interventions. Hysteroscopy adhesivolysis, especially in thin endometrium, is a gold standard to exclude different forms of intrauterine adhesions. Again, you can, depending upon what is the type, you again grade the Asherman syndrome. It is essential if the adhesions are found. Use mini hysteroscope to minimize trauma. Post-operative prevention strategies are critical, but controversial. Previously, we used to believe that after the adhesivolysis, one should put post-operative intrauterine devices or a balloon catheter. But Osama Saki taught us that any of these investigations are really not needed. One can use for 1 or 2 cycles high dose of estrogen therapy, and that will work wonders for 6 to 8 weeks to prevent reformation of the adhesions. Second look at hysteroscopy is often needed when you have treated the severe form of Asherman syndrome. I think Dr. Dash is going to answer this particular aspect. Now, endometrial scratch injury performed in the luteal phase preceding the IVF cycles. It is done in the luteal phase, and the modest evidence is there for improved implantation, possibly via inflammatory or stem cell repair pathways. It is a low-risk procedure, easily implemented, and I think this is almost taken as a fire by all ART experts. Now, thin endometrium, according to the ESHRE recent conference, suggested that whenever there is less than 6 mm endometrium thickness, was linked to notably increased risk of implantation window displacement, underscoring the need for molecular level receptivity assessment beyond just ultrasound measurements. It means ERA analysis is suggested within endometrium. ERA analysis ensures optimal timing for the embryo transfer. By identifying receptive windows, ERA maximizes the chances of successful pregnancy. I again repeat that a personalized embryo transfer using ERA or other modalities to identify the optimal progesterone exposure, that is the window for transfer, maximizes the chances even with suboptimal ET. I will say that it is a high procedure, and because ये procedure की market value नहीं थी, इसको the people who brought it इसको बेच नहीं पाए, and that is why, because of the cost, it never became popular in India, so much so that those people have winded up their shops from here. Now, intrauterine human chorionic gonadotrophin infusion. Again, it is not universal. Many people have tried 500 international unit of HCG alone or used along with the culture medium instilled into the uterine cavity shortly before endometrial transfer. Some studies show benefit in ET and outcomes of the ART cycle, and still it is not recommended. Policy is to keep the procedure simple. Whether it's IUI or whether it's IVF, we should not make it complicated and let the procedure be simple. Now, coming to the adjuvant therapies and emerging options. Again, I will say that, don't be carried away, use judiciously, and always listen who is telling you. Now, acupuncture is a traditional Chinese medicine approach. Some RCTs suggest benefit in improving endometrial thickness and pregnancy rates when combined with the standard ART, likely via improved blood flow. But I will say that it requires a trained practitioners, and it cannot be given by just anybody and anybody. Now, coming to the stem cell therapy, it's emerging and experimental still. Intrauterine infusion of autologous bone marrow derived stem cells or menstrual blood derived stem cells show promise in early clinical trials for severe refractory cases, but not yet standard. It requires specialized center, and the cost is prohibitive, and that's why there are not many takers for this. Now, extended hormonal support. Consider vaginal progesterone supplementation starting before embryo transfer in FET cycles with thin lining, but we all use it routinely in all IVF cycles of ours. It is not specifically for thin endometrium. Lifestyle and supportive measures, again, are very much appreciated and talked about these days, and optimize uterine blood flow. So encourage regular, moderate exercise. Your diet has to be tailor-made. It should be low carbohydrate diet. Smoking cessation is must, and caffeine reduction also should be kept less than 2 cups of coffee every day. I would say that it should be kept at 1 cup of coffee. Now, as for the stress reduction is concerned, I think there are many techniques available, offer counseling and mindfulness techniques plus yoga. I think chronic stress floods the system with cortisol and allied things, and can negatively impact the uterine blood flow. So stress ko to lena hi padega, and you find almost 100% of our patients are having stress and stress and stress. And I think, all clinics must utilize few stress reduction technique, and they work wonders. Adequate sleep is very important, and the importance of this particular thing must be emphasized to the couple, that ensure 7 to 8 hours quality sleep for hormonal balance is must. Manage expectation and offer hope. Crucially, communicate to these patients with thin endometrium that the pregnancy is possible even with ET less than 7 millimeter. So the chances are much, much lower. The success rates vary with persistence, with tailored protocol, and works for many. Avoid absolute cutoffs in your practice. That is my request. In case if it is 6.5 or 6 and you have tried 2-3 cycles, you can try it out, and probably the God may help. Coming to the ART, advanced ART strategies, I can call it freeze all strategy. Avoid fresh transfer in suboptimal cycles. Allow time for a diagnostic workup, targeted treatment for tuberculosis or maybe chronic endometritis or intrauterine adhesions if they're suspected. Especially when patient says my flow of the menstrual flow is less. In such cases, you can definitely think about they can be either tuberculosis or chronic endometritis, and if they are not found, they can be intrauterine adhesions. The preparation of the endometrium in subsequent cycles, dedicated FET cycles, it becomes very easy when you do freeze all cycles, all strategies. So I again repeat, I'm subject to criticism by Brig Sharma and other experts that when I say that avoid fresh transfer in suboptimal cycles. Now, aggressive vitrification. In fact, quality vitrification is very, very important to ensure high quality embryos and the blastocyst are available for transfer once the optimum endometrium is optimized. Whenever you find that, it is said that, good ovarian stimulation contributes to adequate endometrial thickness. So if you find that, your quality of eggs are not good, donor oocyte consideration, donor oocyte must be considered. If the poor ovarian response contributes to inadequate estrogen production despite medication, donor oocytes may be the most effective solutions after addressing the uterine factors. Now, coming to gestational surrogacy, we know this is the first and the last treatment, offers this option early and compassionately as a definitive solution for patients with truly refractory thin endometrium, unresponsive to all other interventions, especially if due to severe Asherman or irreversible, which causing irreversible damage. So the key messages for patients, offering them the hope is, while a thin endometrium presents a challenge, it is often a problem which can be solved in a wide number of cases. We have a wide array of evidence-based strategies tailored to find the underlying cause, whether it is infection like tuberculosis or endometritis, adhesions from past procedures, or blood flow issues. Many patients with initially thinner linings achieve successful pregnancy through systematic investigations and personalized treatment like extended estrogen, vaginal sildenafil, PRP, and use of G-CSF. The key message is, even if we find a lining does not reach the ideal thickness, pregnancy is still possible, and this you must counsel her very softly and not very aggressively. Our focus is on optimizing the health and the receptivity of endometrium using the best tools available, explore all options. If nothing works, advanced technique or surrogacy will help to build your family, that is, patient's family. So the important considerations are combination therapy, often combining approaches like extended estrogen plus sildenafil plus PRP yields better results than a single intervention. Patience and persistence. Finding the right solution may take multiple cycles and a different approaches. Don't give up after one failed attempt. Realistic expectation. While success rates improve significantly with treatment, they may not reach those seen with optimal endometrial thickness. Honest communication is key. Cost and accessibility. Please mute yourself. Discuss the availability and the cost of interventions like GCSF, PRP, stem cells, and surrogacy within the Indian healthcare settings. Now, ESHRE 2025, I went through a few of the guidelines. The treatment for thin endometrium, which they have suggested. Optimize estrogen support. PRP infusions, they encouraged it. GCSF, granulocyte colony stimulating factor, the way I suggested it, that's our protocol, and I think there could be different protocol by other people. Latrose and mild ovarian stimulation in FET cycles, they've suggested that it can be a good alternative. And they have recommended that the natural cycles will be much better, but simple FET cycles are also good. Lifestyle optimization is very, very important and must be emphasized. This changes the whole perception of the couple towards infertility treatment. Hysteroscopic evaluation in thin endometrium is must. Monitor the window of implantation because it has been said by them and emphasized anytime when you find the endometrium thickness is 6 millimeter or less, please look for window of implantation by doing tests like ERA. Stem cell based therapies are also suggested. They are experimental. They are costly at this particular stage, but it's worth trying. And personalized AI-based ART protocols are going to be the solution tomorrow. And I think the experts are going to highlight on this particular point. So this comprehensive step-by-step approach addresses the specific concerns raised with thin endometrium. I will emphasize again tuberculosis, chronic endometritis, undiagnosed intrauterine adhesions following the DNC, which patient has not been able to disclose, and a roadmap of proven and emerging therapies offering tangible hope and actionable solutions for patients struggling with thin endometrium in ART. Thank you very much.
Thank you, ma'am. I think it's a very, very clear roadmap you have given for thin endometrium. And it was a very, very crystal clear talk. So let's hear from our experts. First of all, I think we will ask Dr. Brigadier to conclude in end after taking opinions from Dr. Aruna Saxena, Dr. Vandana, and Dr. Shalini. Dr. Aruna Saxena is there? Dr. Vandana Gupta?
Shalini is here.
Shalini?
Yeah. Ma'am, hats off to you. Only you can cover such a complex topic. You have covered everything. I mean, not even an iota of anything, any investigation, any treatment which you have left. And in such a lucid and easy manner. I think everyone, whosoever is listening, it's their benefit, and whosoever is not listening, it's their loss. So I think I have nothing to say. You have covered it so well. The only thing is, like in my experience, once the endometrium doesn't work, at times, the patients doesn't respond to the estradiol. And if there is no history of prior any DNC or any intervention, then at times the natural cycle or the mild stimulation, either with the letrozole or with the mild, very little dose of gonadotropins, these patients, they respond beautifully to the mild stimulation. And of course, we have to be very, very practical and, take the history. At times, the patients do not disclose, but there is a history of DNC where it leads to Eschermann's, and then there is a thin endometrium. In few cases, I have found, like we see beautiful endometrium, 7 millimeter, it doesn't grow. But if you do a therapeutic hysteroscopy, I think hysteroscopy is the brahmastra for where the thin endometrium is there. It really works beautifully, even if there is no adhesions. Even if we do the scratch, the endometrium I have seen grows beautifully just after the scratch or just snipping at the fundus. Of course, in measurements, Dr. Dash would be covering it. So these are my take on points. That is how I treat the thin endometrium. And of course, these empirical treatments, GCCSF, PRP, we all try when we don't have anything. In few cases, we are successful. In few cases, we are not successful. But yes, right, left, center, we all use it in all these cases when we don't have anything else. Regarding sildenafil, yes, it works in few cases. The only thing is that it causes a lot of headache because it is a vasodilator. Rest patients are okay. RG prime, vitamin E, we all use it, ma'am, because we don't have anything, these resistant cases. And we take the cutoff. I mean, the recent guideline says that in fresh ET, we take, or in the natural cycle, we take the cutoff as 7 millimeter, and in frozen embryo transfer, we take the cutoff as 8 millimeter. But yes, we have to evaluate whenever we are doing a transfer. At times, there are patients when their inherent ET does not grow beyond 6.5 or 7. Then I think we should not hesitate to do the transfer, because until unless we have to take the chances. If we do not try, we will not succeed. So that is my take on messages after your lucid talk, ma'am.
Thank you. Thank you. Yeah.
I failed if I will not add up. I have heard Brigadier Sharma teaching our girls in earlier days that, whenever you have suboptimal endometrium, it is good to transfer instead of two embryos, you transfer 2 or 3. Then you find the pooling effect will work, and the pregnancy takes place. So I think we will wait for his comment
Yes.
again.
Yes.
Sharma sir, over to you.
Brigadier Sharma?
Sir, you
Sir?
are muted.
Can you hear me, madam?
Sir,
Yes,
abhi
please.
sunai.
Yeah. So excellent talk by Sharda ma'am and good inputs by Dr. Shalini. We covered almost every point. So I just want to add a few things on that. We have to also, exclude viral infections also of the endometrium. We do not have any test for that as such available easily in India. But clinically, when you do the ultrasound, and if you find repeated some fluid is there in the endometrial cavity, so that means we have a nasal flu, there is a endometrial flu. So whenever we have a nasal flu, we have nasal secretions. So similarly, when there's endometrial flu is there, endometrial secretions. So if you have thin endometrium with the fluid in the cavity, think of viral infection and give them the acyclovir. The second point is about the GCSF. It is mentioned that you can be given subcutaneously also and intrauterine also. The problem with the subcutaneous is sometimes the patient can have very severe bone pains after giving injection. So preferably, I think we should give it intrauterine. And if you are giving subcutaneous, then some painkillers should be advised. Otherwise, the patient will call you in the night to say, "Doctor, I'm having a lot of pains in all the bones." And another issue is, couples should be encouraged to have a regular intercourse, especially when you're doing FET and all, because that also helps in improving the circulation and also helps in the better implantation by the protein called spermidine, which I keep on mentioning all the time. And sometimes, the local Hemeract gel vaginally, where we cannot give sildenafil because the patient is having hypertension, complaining of headache. So Hemeract gel can be applied into the vagina. So I normally tell the patient to put it on wash hand, put it in the finger, and apply it inside by herself only. And it helps in improving twice a day. It improves the endometrium. So that is also a arginine only. So instead of giving orally, if you apply vaginally, it works good also. Now another point in the thin endometrium is that sometimes you find at the basal layer there is small dots of calcification below the basal layer also. Now those are the endometrium which are having a real chronic endometritis, and they are the most difficult to treat them. And histoscopy will definitely help us. And as mentioned by Dr. Shalini, sometimes we find calcification and the patient doesn't give any history of abortions. But when we do histoscopy, we may find small bones all as well. So which remove the fetal bones and then the endometrium starts growing well. So these are a few points I thought I'll share with you.
Thank you, sir. And I think very well summarized by sir, and great inputs from Dr. Shalini as well. So whenever we are stimulating our patients, it's very important to keep a watch on how endometrium is growing. Because sometimes what happens when we do frozen embryo transfer and we are taking our patient in HRT cycle, and we look back at the card, the monitoring which was done during stimulation, and if we see that there was a beautiful endometrium, then for sure by it's just a matter of time, by one method or other, that patient usually makes a good endometrium. So I always go back to those cards of monitoring and look at when I stimulated the patient, then how good the endometrium was. That gives you a very good clue. Dr. Shalini, with you, this regarding sildenafil, you said headache, but if you give it vaginally, then the headache is not there, because then those systemic side effects are usually not there. And this is another observation which I am seeing these days. This hemihydrate salt which is available given vaginally is those, and endometriums which are really getting stuck, they come up well if you add Easter. I don't know, Dr. Sharma sir, are you using hemihydrate salt? Because I'm finding it really good in stuck endometrium
Yeah,
cases.
especially when the well rate doesn't work, then I switch over to the hemihydrate to the next cycle and find it response. So
In fact,
possibly the receptors, behave differently with the two different molecules.
even
Right, sir.
the gels, the gel form, it really works if the patient doesn't respond to the oral. So if the patient
Yes.
doesn't respond to oral, I do try either the gels or the vaginal preparations. Even the Progenova also, you give vaginal, it works. So
Right.
hemihydrate, vaginal patch, gels patch is not available.
Yeah.
All
So
these,
sometimes you need to change the route and it gives you better results. And one more thing which I have really seen and I would want to share is that, when nothing is working, give break to your patient, especially when her stimulated cycle had a very good endometrium. You are trying HRT, didn't work. Again, another cycle, it is again 6.5. Just give a break of 2-3 months. The drugs gets washed off the body. And then again, start preparing, it comes up well. So I
very,
think a lot of
I
patience
agree.
also is
Very
needed,
good.
and it
Yeah.
it works.
It works. Truly, it works. Somehow, in fact, you are surprised that after the stimulation, the endometrium doesn't grow, and there is no reason for it.
Right.
Yeah.
So let's move